don't know.
Good evening, friends. Welcome to the Saturday evening webinar of CSI Delhi branch. We have a great pleasure in inviting you to the first webinar of the Intervention Cardiology webinar series. And today we have the pleasure of having Professor P.K. Goel. He'll be speaking on the art of coronary angiography, performance, and intervention. We have the chairpersons here joining us, Professor Harshvardhan, who is professor and head of the department in the Mahatma Gandhi Medical College. We have Dr. Vinod Sharma, who is CEO
There is
and head
some
of the cardiology.
disturbance at the back. There is some sound disturbance. Okay.
We have Dr. Harshvardhan, who has joined us today. We have Dr. Vinod Sharma, who is CEO and head of the Department of Cardiology at National Heart Institute. We have Professor Nitish Nayak, who is Professor of Cardiology at All India Institute of Medical Sciences. And in the moderation, we have Dr. Ankit Bansal, who is Associate Professor of Cardiology at GB Pant Hospital, and myself, Dr. Mohit Gupta, Professor of Cardiology at GB Pant Hospital. So over to Dr. Nitish Nayak, Dr. Harshvardhan, and Dr. Vinod Sharma for starting the session.
Dr. Harshvardhan, you need to unmute yourself, sir.
Can you hear me?
Yes, we can hear you now.
Yeah, I am unmuted. Dr. Mohit,
Yeah, please, sir, start.
can you hear me?
Yes, sir, please start, sir. We are already through.
Okay.
Please.
Yeah, okay. Thank you very much for starting this in interventional cardiology after a grand success of your PG track program. And I think to start this interventional cardiology, the best topic would be to interpret the coronary angiograms. And I think to interpret the coronary angiogram, there is no person better than P.K. Goel, who has worked a lot on interpreting coronary angiogram and have written a lot of papers also on interpreting coronary angiogram. I think let's straightway go to Dr. P.K. Goel, and after that we can come to discussion and question answer after he has given his talk. Dr. P.K. Goel is Professor of Cardiology at the SGPGI Lucknow. May I request Dr. P.K. Goel to start the talk?
Yeah, thank you, Dr. Harshvardhan, and thank you, Mohit, Nitish, and everyone there from the CSI. Indeed, it's a pleasure to talk to the Delhi group and the residents who probably must have joined, or the young cardiologists. So let me just share the screen in a moment, please, if you will allow. Just a sec. I don't know. Is my screen seen? No, not
Yeah.
Is it seen?
Yes, sir. Please go ahead, sir.
You can see that. Okay, fine.
Yeah, full screen and start.
I can't see your screen.
Okay. Can you see now?
Yes, sir. Please go ahead, sir.
Okay. So what I am going to talk is actually this is a topic which is very close to my heart. I keep speaking on it. So you will forgive me if I get ashtrays or out of track, because I can speak for hours together on this. Actually, the art of performing and interpreting a coronary angiogram, I have made it art because it is a science, but I think doing a good angiogram and its interpretation has a lot of features which are arts. And this is something which is very basic, but maybe we lose that as we become more and more senior. So I would think this is everything that an interventionist must know and could help every interventionist at some stage or the other. You see, performing a good angiogram and its right interpretation forms the basis of a good coronary intervention. This is, I very strongly believe, and at every forum and every case that I do, I can tell you is the angiographic interpretation. It gives me a long way to go. It is an art which is often taken for granted. If I want to teach angiogram to a cardiologist who's already trained, he'll say, why do you want to teach me angiogram? Yeah? And even the residents, they want to be taught more of angioplasty. The angiogram everyone knows. So this is the parody. So an art which is often taken for granted and not uncommonly, I can tell you, is lacking in good number of interventions. A few basic angiographic principles, I will talk of that just to complete things. Know the anatomy and outlines of the heart chamber, because the coronaries will run along the outlines, like something will run in the anterior interventricular groove, something will run in the posterior interventricular groove, something will run along the AV valves. We know all that. But when we are seeing the coronaries, so see the heart behind it like that, and then you will probably understand it better. Coronaries envelop the heart in 3 dimensions, but are visualized in 2D on a flat plate. So you must know that. Visualize the heart behind the coronaries in a coronary angiogram always, and get the concept of distance. 2 points lying close together in a single view could be miles apart in another. Like, I hope you realize what I'm saying. So always, that is why always view in at least 2 orthogonal views, and understand the concept of parallax. Parallax is when there are 2 structures which are close together on the surface of the heart, which is a circular or conical shaped structure which is moving, contracting all the time. So if there are 2 structures close together, they will move together. But if they are on the opposite walls, they will move in opposite directions. So you can easily sometimes in single view differentiate a OM from RCA just by its movement. Now this is, I think I'll just, this is for beginners. You see right, left, cranial, caudal. And image intensifier actually is an eye. If you believe that, you have to understand that we call it II, image intensifier, but it is the true eye, because that is where the image is formed, and like our eye forms the image. So if we are seeing from the image intensifier is always in front, so we see it from the left shoulder, or the right shoulder is the RAO view, left shoulder is the LAO view, and then we have the anterior and posterior. So get these concepts very clear in your mind. It will always help you in understanding things when things are complex. Now, this is something, a very straightforward angiogram showing the right coronary in RAO, in LAO view, and then RAO view. Nothing great about it, but I will tell you now something, a tip, which I'm sure people, no one would have told you. Now, what is the tip? Now, this right coronary has 2 branches. Oops. It has the PDA and PLV, we know that. Now, how do you differentiate that in RAO? I don't know if anyone, incidentally, this doesn't remain an interactive session, so I don't think I'll get an answer. So I'll tell you suo moto. Now you see the RAO view, you see one vessel going up from the tip, the other staying back. There are 2 vessels, RAO view, and one vessel is going up and the other vessel is staying where it is at the apex, at the tip. The one that is staying behind is the PDA, and the one that is going up is PLV. Always it will be like that. Always, believe me. I don't know how many people know that. Okay. So now this is just to show the coronaries in a AP or RAO type of view on the left and a LAO type of view on the right. Well, we know that in the AP view, you get the ventricles and the atria separated. In a LAO view, the AV valves look end phase. So the right will run as a circle on the right, and the left, that is circumflex, will run as a circle on the left, and the branches will all hang down from this circle towards the apex. So that's how it is. So if you want to differentiate or separate atrial branches from ventricular branches, the best view is a RAO type view. And the other thing which I wanted to show was always in a RAO or a AP view, LAD will never be border forming. Always LAD will be inside the contour of the heart, as you see, because the interventricular groove, which is the surface marking for the LAD, is on the anterior interventricular groove, which is 2/3 RV, 1/3 LV on the front, as we all know. So the boundary is not the LAD. Sometimes you believe that the boundary will be LAD. No, it is only when you start going more and more RAO that the boundary starts getting formed by LAD. Otherwise, LAD will always be inside, the diagonals will be in front, and septals perpendicular or further inside the LAD. This is a line diagram, which is a very nice thing to remember. Well, I have a series of them, but I'm just showing one because that runs more for congenital heart disease. But now you see this is the LV and the RV in a RAO view. You have the AV valves outlined in dotted lines, and this gives you the impression how the arteries will run. This is the interventricular groove. You have the posterior interventricular groove. How the arteries will run in a RAO view, how the arteries will run in LAO. This is the two C's that I was talking about, the two circles, the two valves and profile, the AV, the mitral and the tricuspid with the RC and the circumflex running down. And this is a LAO cranial view. What is happening is the same two circles are there, but a little lesser in profile. And this is also called the long axis oblique view, as you all know. So you have the arteries hanging from the top downwards, and that is what exactly is happening. And you will be, so if you have these concepts, you will know things more. One LV angio I want to show you. We're going to talk on coronaries, don't worry, but because there's certain things which you will never see again. Now this is a LV angiogram on the left. This is another LV angiogram on the right. I wonder what is the difference between the two. I don't know how many people made out what's the difference. I will show you the difference. So this is the systolic frame of the one on the left, and this is the diastolic frame of the same one. This is the systolic frame of the one on the right, and this is the diastolic frame of the same one. The difference is here, as you see, the LV outflow tract will always overlap the inflow, as we know, because the way the heart structure is. So when in diastole the ventricle is filling, the AV valves are open, so non-opaque blood is coming into the ventricle. You still see some contrast here in the LV outflow, and you have a line here. I don't know whether you can see this line. There is a straight line at the AV valve level, but here that line is not there at all in the diastolic frame. This is the atrioventricular septum. Whenever you will do a LV angiogram in RAO view in any patient, you will always get this diastolic contrast hanging in the LV outflow tract because it cannot clear. While here, because of the inlet VSD, this is what is AV canal defect. And you will never see that line. And that is the difference between them. That's normal and that is AVSD. So that's the only thing I wanted to tell. Now only coronaries, nothing else. Now, often committed mistakes in a coronary angiogram is a poorly performed angiogram. You can't ask me to interpret an angiogram where it has not been performed well. If it has not been performed well, I cannot interpret it correctly. I can assure you of that. I will tell you a lot of things on that. Injection done during partially hooked coronary ostia, and these are all not uncommon, I can tell you, especially from smaller centers when you get angiograms from the periphery, from where people are doing about 50 angiograms a year, 50 angioplasties a year, or whatever, some smaller numbers. Injection done during partially hooked coronary ostia, arteries either showing layering of contrast or remain unfilled altogether. You will always underestimate, overestimate stenosis. You cannot make out things. Inadequate number of shoots taken. Several people have seen angiograms done, 3 shots for RCA, for left coronary, 1 RAO, 1 RAO caudal, 1 RAO cranial, and something for the RCA. There is no orthogonal view. There is no LAO view. You always need 2 orthogonal views, I told you. And so very limited views and, well, selected views, I don't know how. Blocked contralateral vessels. They have not been shown in the field of view from the contralateral vessels because this may be the only opportunity to see these vessels. Now, supposing I am doing, there's a case with blocked LAD. I want to see his LAD in the left injection. It will not be seen because it is blocked. So how do I see it? From the right. So, but from the right, I will see only if I pan towards the left. If I don't pan towards the left during the right injection, and that too during later part of the injection, then only that distal LED will be seen, and I will be able to assess what to do for this case. Otherwise, I will never see it. Injection and viewing has to last long enough so as to give time for the contralateral vessel to fill. If it doesn't last that long and you just give a boom, shoot out, you will never see that vessel. It will never fill, and you will say LED not seen, over. That's not done. Every vessel will be seen, I can assure you. Invariably, you will remain blind on the LV side, and this is good. Consultants I am talking about, they will never do LV. I understand that there are reasons. Well, contrast load increases, whatever happens, blah blah. But the fact is, you remain blind towards LV, and then you say you have the echo, no problem. So the echo guy tells you the ejection fraction is 40%. Today he says 40. The same echo done tomorrow is set 30, and the day after is set 45. There's a big difference between 30 and 45. So, and you can't replay it unless you record it. All echoes are not recorded, and you don't have it at the time you are seeing the angiogram. Now, LV is a must, at least for people who have had MIs, so that you can see the LV right then in front of the arteries, because LV is to coronaries as brain is to human body. So you have to have the LV. Without a concept of LV, what is the LV? I can't make decisions on coronaries. So that's wrong. So, and believing on that second hand up, because everywhere there are very few centers where there might be committed cardiologists who are only doing echo, beautiful echo, and really good work done. Otherwise, echo is you put a transducer and you get a rough eyeballing ejection fraction. The story ends there. You don't know what's happening. The other thing, angiogram is a dynamic picture and needs to be understood as a collection of frames in one shoot, rather than a single snapshot picture or a photograph. Understand this, what I'm saying. Hence, nearly there are 300 to 400 frames to be interpreted by your brain computer. Your brain computer will do it very fast, but you must tell your brain computer that I have these 300 frames in these 8 shots. Because if each shot lasts for about 40 frames, 12.5 frames per second, and the shot lasts for 3.5 or 4 seconds, the injection, you will get about 40 frames. So these 40 frames make about 320 frames total. So unless you tell your brain, please analyze 320 frames and then give me the answer. Because every frame I tell you, the filling and analysis things are different. Analysis or interpretation of lesions similarly along the length of coronary vessel is to be done in a fashion similar to inching of a murmur. You have learned the inching of a murmur very nicely, because the teachers tell you, you have to inch it every millimeter. Then you will know whether there's a tricuspid murmur or mitral murmur or murmur from the base, from where it started, where it's going. So similarly on a coronary angiogram, you have to inch every millimeter of the length of the vessel. Maybe there is some napkin lesion which you are missing. Maybe there is a very short segment of moderate disease or a very long segment of moderate disease which your eye is overlooking because it is seeing one discrete stenosis somewhere, because that is what is the oculostenotic reflex. So all these things will not happen if you will ask your brain computer, please see it inch by inch or millimeter by millimeter. So this is what it is. The technique of angiography in every cine run have an initial dry fluoroscopic part. Never people do it. Generally, I am saying what it is going to show you. You will see calcium only in the dry part. You will not see it after the injection has happened. You will see hanging contrast of thrombus only in the dry part, not after it has happened. So always have a dry run and then use the term inject, so that then your assistant will inject. This is what you should teach to your assistants. Contrast flow rate to be commensurate with the normal flow rate in that chamber and the or the capacity of the chamber or the vessel concerned. This is a general principle because you somehow need to transiently fill the entire chamber or the entire coronary tree that you want to see with contrast. So you must give enough volume which will, one, fill the entire system, and it should be fast enough that it can opacify the whole chamber very reasonably. Say there is the concept of blue ink and red ink as is taught in congenital heart disease. If I keep injecting 1 millimeter of contrast, a tiny ml every minute, it will keep entering and passing off, entering and passing off. It will never ever opacify the full artery. So that is why you have to fill it and follow the dye as you inject, even in a coronary angiogram. Certainly on a congenital heart disease, but even in a angiogram, that is where your inching will also happen, right? See it as it goes into the left main ostium, into the bifurcation, into the proximal LAD, mid LAD, and you will know what is happening in the entire artery. Now, steps in coronary interpretation. So that was about performing. Interpretation, first thing, you need to identify the anatomy. Because no two coronary anatomies are same, I can tell you that. Everyone knows it. So identify all the vessels in the. That is why I do not believe in the pre-drawn diagrams. I have my reservations on syntax score, which talks of every branch being scored depending on the name of the branch. OM is a OM, irrespective of how big or how small it could be. I don't think I'll be able to cover that part because everyone is conversant with syntax and everyone follows it. I'm not saying not to follow it, but I'm just giving you a piece of thought because you all know, you have seen ramuses and OM, ramus arising from the division of left main, which is so big that it covers the entire circumflex territory, and the main circumflex has nothing to do, right? So this will make all the difference for you to understand. You can't call this ramus the same size as a tiny little PLV or a tiny little OM from somewhere else or whatever. So anatomies vary. So I will give you the concept of how I tackle that different anatomies. But so first thing is to identify the anatomy, identify all the vessels in the patient, variations in the branching pattern, variations in the course, if any. Branching pattern will always be different, will be very different, but course, well, anomalous could be only very few patients, agreed. A myocardial value, you could do objective myocardial value. Well, I give objective myocardial value because I follow one system. Maybe people know that I follow the green lane system, but whatever it is, a concept of myocardial value should be there. That is how you will decide on which vessel to intervene and which not to intervene. You may indirectly call it the importance of each vessel, and or each independent diseased segment has to be weighed. Then you have to do a stenosis analysis, how much, how severe, where, and then you have to make a final recommendation. So these are the 4 steps to an interpretation. So what is the most important information? What is the more important information? Now, this is again something which we always miss. In a case, supposing a case is surgical, right? Just think about it. What does the surgeon need? He practically needs, अरे भैया कितने graft लगने हैं? How many vessels are there? How many independent stems are there which are calling for grafts? And how is the quality of that distal vessel? And quality of distal vessel, there is no area to comment on it, and I am yet to see an angiographic report where anyone has commented on the quality of distal vessel. No pre-drawn diagrams have an area of quality of distal vessel to be commented upon. And number of vessels or branches independently disease, well, we say 1, 2, 3 vessel disease, LAD, circumflex RCA or something, but each independent stem has to be accounted for, and that is how you can aim towards complete revascularization. There is a lot of issues on that. Now, and then the details on the number and types of stenosis actually is not crucial at all to the surgeon. As long as you You can tell him, boss, this is a very severe disease in the LAD or a critical disease. You can say it's critical, it is severe, it is moderate, no problem. Now trying to tell him there is a 70 followed by 80 followed by 90 followed by 50. What the hell is he going to do? He only has to graft the distal vessel. And of course, LV is very important for him. Based on the LV only, he will make decisions. And so several of these things, most of these things, we are not giving. And for angioplasty, what you need, if it is for angioplasty, this is where you need the proximal course of the vessel, the anatomy exact, the branching of each pattern, branching patterns, exact locations of the stenosis, how many stenosis, 70 followed by 80 followed by 90 followed by 50. So you need to know it because you need to tackle each of them. And of course, it is good to know the distal vessel, even in patients with angioplasty, because unless there is a good distal vessel, you will not get the runoff, and LV is equally important. So I am trying to highlight these things for you to understand. We falter how much? Everyone is in different center, I am sure, and he must agree with me that we hardly comment on quality of vessel. We hardly comment on the independently diseased segments. We only talk of vessels as described by the American College of Cardiology. We hardly do the LV. So these are things which are important. Pitfalls in a coronary reporting. That was the things needed. Now, the pitfalls that are there, each individual coronary anatomy, as I told you, is somewhat different. Pre-drawn diagrams cannot accommodate for this difference. Freehand diagrams do not have the reproducibility and teaching ability. Several places you have free-drawn diagrams, they try to draw individually and give you. But then they don't have the reproducibility and teachability. You may get led away in one direction. Most reporting systems do not have importance laid to the size of the vessel. That is the myocardial value of that vessel. Size is not by the diameter. Size is by what big area of the heart that vessel is supplying, which is the most crucial factor in any decision making. And if you start doing this, a lot of your patients which you otherwise would send for surgery could convert into angioplasty, I can tell you that. Because you are saying triple vessel, because as I told you, there's a big ramus. If that is normal and a tiny little circumflex with no branch is having 100% stenosis, why the hell should I send him to surgery? You tell me that. Okay. They go more by the name of the vessel, independent of its size, which though usually correct within extremes, may not always be true. So ideal interpretive requirements is identify all independent stems with significant lesions rather than trying to count 1 to 3 vessels. Disease, branching pattern, course and sizes of each stem to be known, especially if the case is for PCI. Myocardial value or importance of each to be understood and expressed. Stenosis analysis to be done. Then a score to be calculated and final recommendation. So this is the Green Lane paper. This is one of the ways that we do. I think this is one of the important or only published ways of reporting on angiograms. So the Green Lane system, and on that, well, I wrote a paper in 1997 in the Indian Heart Journal based on in the interventional era, because that system was made in the non-interventional era. So maybe there are certain things which were more important, so we modified it slightly. We don't have time to go into the details of that, but I will just tell you basically what it is. The coronary diagram is, again, as I told you, remember the heart behind the coronaries. So this is the basic base of the diagram, and this is what? This is the heart. This A stands for apex, and this is the circumference, the LV, the ring of the mitral valve, and on right side is the ring of the tricuspid valve, and this is the interventricular septum, the anterior, and then posterior behind. And once we know this, we can always put the arteries in their respective place. And once we put the arteries, we can, there it is, the arteries come in their respective place, the LAD in the interventricular septum, so 2 diagonals here, depending on exactly how the anatomy was. So that this OM was average size. Now RCA is called PDA, dominant, non-dominant based on PDA, but there could be RCA which is only PDA, that is also RCA dominant, and this RCA with all PLVs and everything is also RCA dominant. But there is a difference, because if it were only PD, then this would have been much bigger, the OM, and then the circumflex is more important in weightage. And then you get the stenosis, and then these are the stenosis being added on the LAD, diagonal, circumflex. So exactly where the stenosis is, after 2 branches, we have 100. I have the provision to do that. And beyond that, there are 2 branches because I have seen them through collaterals and everything. So all provisions are there, and it will never take you haywire because it will stop you. If you made the circumflex really big, it will not let you get the RCA big. And that is what happens in real life. If circumflex is big, RCA has to be small. So our weightage for RCA has to come down. Off late, we are working on a computerized system for this, what I'm talking about. And maybe I'll be able to provide that, which will be, and get a score which will be similar to syntax. So I believe that there are limitations and fallacies in syntax. I have explained to some extent. I will not go into the details of that. We published that also some time back. And if someone wants, he can read this paper and understand things for himself better. Then comes the standard coronary angiographic views. Well, as I told you, doing 3 views and all RAOs, I don't think that's right, but that's a different matter. But now this is something which I would say for the beginners or the learners, if you want, you can take a snapshot picture of this, and this, because I don't think you can remember this or mug it up right now, because this is exactly what it is, and you should do these views. First, always hook the left coronary in a LAO view. Why? Because LAO view separates the left sinus from the right sinus. So you know you are going in the left sinus. Several people in the olden days had been taught with the Judkins catheter. Today we are doing radial procedures. Judkins catheters, it gets into the left coronary on its own. So AP view, they used to just put the catheter, used to get in. But no, now we want to hook it actively and not hook it very deep, not hook it less deep. So always in LAO. And the first view that I always advocate is LAO cranial, and the reason is left main ostium. I'll show you example that why this is so. Left main ostium is best seen only in LAO cranial view. That is what it is. Believe me for my word right now, and you will have enough time to prove the same. So LAO cranial view is the best view for that, I tell you. And so the first thing you want to know is how's the left main, and especially the ostium gets missed. In RAO view, ostium is always end on and you will never see it. And then there are series of views. RAO view shows you the general overview of the system with the left main and LAD circumflex division. RAO caudal shows it similarly. AP caudal shows the proximal circumflex, proximal LAD very nicely. LAO straight view, best for circumflex, shows the circumflex beautifully, and I would advocate interpreting circumflex stenosis only in a straight LAO view. And a lateral view, this lateral is 90 degrees lateral, 10 degrees cranial. It is very good for mid and distal LAD. Lesions in mid and distal LAD sometimes are not even seen in a RAO cranial view, and they are seen sometimes only in a lateral view. And RAO cranial view, of course, is for the entire length of LAD, except the origin or the division between LAD and circumflex, which will always be overlapped. So will it be in LAO cranial view. And then you have some optional views, especially if it is a horizontal heart. Some people have a horizontal heart. Usually the heart is a vertical heart. If you have really obese guy with a horizontal heart or the heart apex going up, that is a patient where a so-called spider view might work, or a LAO caudal view or a AP caudal view for division of left main bifurcation. It will show it better, and that's it. The coronary RCA, I think we know this LAO, RAO is the standard views, and then we can do some optional views for the crux, the LAO cranial. Steep RAO cranial is good for distal ramification of the RCA vessels, especially distal PLV, distal PDA sometimes. And then to differentiate PDA, PLV, I showed you the example angio, that if you remember that PDA is going to stay back and PLV is going to move up at the apex when the heart contracts. Okay, so these are line diagrams showing the pictures. This is how the standard LAO would look, and this is how it cleans up the crux. area in a cranial view. RAO straight has these overlap of PDA PLV, which gets separate in RAO cranial view, as I told you. Now the other thing is in RCA hooking, several times you make a mistake. In LAO view, you have hooked the RCA, but in RAO, if you will see, the catheter will look like this. It is not in line with the circumflex, with the RCA. And this actually needs some more clockwise rotation, and then it becomes like this. But this will also get your catheter deeper. So if when you're doing angioplasty, it's good to have some more rotation, make it more coaxial. Otherwise, you will feel that in LAO view, everything looks good, but my things are bumping out. They're not going. What's going wrong? So because you are not truly coaxial. So this is to understand that. And then when you're rotating catheters, understand that it takes time for torques to get transmitted to the catheter tips. So wait for a while before the rotation is going to happen at the tip. It's not that you rotated, it didn't rotate, you rotated 5 times, and then by the time the action is going to happen, it's going to rotate towards the RCA mouth and then immediately jump off because the torque is too much. So do give one torque, wait, and then see the transmission of the torque, and then get the next one. A little word about graft angiography, always native vessels first. Understand the paradox of the amount of filling through native injection. What is this paradox? I do the first shoot in a post-CABG patient on the native left coronary system. I see the entire coronary tree. What is it? All grafts are blocked. I see nothing. There's LAD is 100, circumflex is 100. Best for the patient. That means all grafts are working. This is indirect. General idea. 2 injections each for LCA and RCA are enough because you're not here chasing the divisions of the left main, LAD, circumflex, because that's all bypassed. So there's no point doing all those injections. You do 1 RAO, 1 LAO, and that's more than enough. 90% SVGs are hooked with the JR catheter because you are interested in the injections through the grafts, because that is what will show the distal vessels, and accordingly you will do the views. And hooking view is important. Right grafts, remember this, what I'm telling you, right grafts will get hooked in shallow LAO, will be profiled in shallow LAO. Left venous grafts will be profiled in shallow RAO. So remember that. And for Lima, select the subclavian in LAO. We know that because the arch is open, we always select it in LAO. But probably where we miss is, and then we advance the catheter. When you pull back in RAO, not in LAO, because in LAO, the subclavian artery, first and second part, gets foreshortened, while in RAO, it is all elongated. So you will be able to reach the mouth of the Lima. You'll have more distance to reach the mouth of Lima in RAO. This is the picture which is showing that. You see, this is the standard LAO view. You see, none of the grafts are in profile, as you see. They're all arising from somewhere inside the ciliate. Profile means they are arising from the ciliate of aorta. Now you see here, this is the shallow LAO view, and you see the RCA graft is arising and it is in profile with the ciliate of, so that the moment you are tracing the aortic margin and you, boom, you will enter it here. And similarly, in a RAO view, see the left grafts are all in profile, while the right ones are not in profile. But very difficult to hook in this position. You can always hook when it is along the border of the aorta. This is the RAO view of the left of the subclavian, which I was talking of, and the Lima can get hooked through here. You can hook it through JR also, but or else you can exchange to a Lima catheter after having crossed. I think I will just talk about some tips and technique. You see, we are doing radial procedures these days, we know that. So radial procedure problems always happen because of pain. The pain produces spasm, the pain produces vasovagal, the pain produces everything. So you have to have a painless procedure. And how do you make it painless? The local has to be very good. And how is it very good? always make a intradermal wheel, because the pain fibers are all in the dermis. We learned that in anatomy. They're all in the dermis, maximum pain fibers. So unless you give an intradermal wheel where you get the blood in the injection is intradermal, you will not get that anesthesia. And if you make the patient's procedure painless, and of course with a little more experience and expertise, your catheter movements are more smooth. So it is jerky movements of the catheter, pain of the patient, which all produces learning experience problems with. And then vasovagal, I'm going to tell you one word on that. Vasovagal several times happens during coronary angiography, and it is always good, or even during angioplasty. I think at least 10 to 20% patients at some stage will have a vasovagal that you are doing. And at the first fall of heart rate, suspect that it is going to happen before it truly happens. That's what I do. I give atropine. I started the case with a heart rate of 78, and there is some problem. Patient is not feeling very well, good, and the heart rate is 62. I know he's having a vasovagal. Handling catheter damping. As I told you, rotation is in the right direction is more important than pullback. Say for the right coronary, if clockwise rotation got it more coaxial, anti-clock rotation will make it less coaxial, or will make it get it out of the mouth of the coronary. So if you pull it back, then it will bump out immediately. So always handle it by rotation, and rotation in the direction opposite to what hooks the artery. Like LAD is always hooked with the anti-clock and advance. So if you want to undo that, you will do clock and pull. RCA circumflex is hooked more by clock and pull. So maybe a little anti-clock and advance will get you out of the circumflex, and then you will not get damping. And the other thing is always allow natural bleed back to occur from these arterioles. They are positive pressure systems. There's big pressure inside. So the moment you take out the wire, there has to be back bleed. If there's no back bleed, you don't need syringe to suck and then get things. That means there is a problem. So always allow natural bleed back rather than active suction. Now, some important differentiations, LAD from diagonal in RAO view. Now, this is where the concept of parallax is going to come, which I talked initially. A blocked diagonal or OM, they are both running parallel to each other. They're similar type of vessels. For me, they make no difference. It's just a name. They're very close. As in my diagram, you saw the diagonal territory ends and the OM territory starts. So if a big diagonal, it will run into OM territory. A big OM could run into diagonal territory. So this has to be differentiated from a RCA, which is on the opposite side. A PDA from PLV in RAO. That I told you, I showed you the example. So look in a orthogonal view. Well, that is the ideal, but you can also use parallax and make out whether these two arteries are in the same plane, so same close together or away. Now, this is a picture which shows that. Now, you are seeing a artery filling through collaterals during later part of the injection in the left. What is it? Now, is it OM? Because you see it's almost going up and it's looking as if it's connecting to the blocked stump there. You could always think it's OM, but when I do the the LAO opposite injection, this is that vessel. You see it's running on the opposite side. It's running on the right AV groove. So this is a branch of the RCA. It's nowhere OM. And if you see by parallax, you can make that out here itself. You see this. This is the diagonal branch, and this is that vessel which we're talking about. They are moving across each other. With contraction, they are moving across each other. So they are not close together. They are miles away. You can make out in the single plane also, but this orthogonal helps you. The story of missing vessels. Well, you have 100% blocked vessels, as I told you a little in the introduction about it, but they are invariably seen through collateral filling. And I can assure you, when a vessel is blocked, it will always be able to see it. Several times in acute occlusions also, you will be able to see it. But yes, acute occlusions, there could be a position where distal vessel is not seen at all. But if you don't see the distal vessel, then either it is an acute occlusion or it is an anomalous vessel origin, that is, it is arising from somewhere else and you have not hooked it there. Or it is, maybe it's something like very close, it is arising, it's not truly anomalous vessel, it's not anomalous means arising from the right side in the left system, but maybe it is double orifice left main or something like that, that is very close together, but you are just missing it. So these are the ways, because several times I see CTOs LED blocked and the interpreter has said distal LED not there because LED is blocked. No, it will never happen if it's a CTO. You will invariably see it unless it is a dead scarred territory, which is very, very uncommon. Okay, so more often than not, where lies the catch is that you miss blocked or anomalous vessels, because the primary key working at the back of the cardiologist's mind is the vessel by name and not by myocardial territory. You see, when you work on a system like the diagram that I was telling you, you will see that maybe one OM came, which is patent, which is very small, and the RC is also not as big to cover the entire OM territory. So I'm sure there must be something missing. If you apply that logic, then by looking for a void in the myocardial territory supply, and the diagram that I've been doing it for 30-35 years now. Well, not a single case has not gone with the diagram. Well, this is just a question of consistency. Well, I'm doing it, doesn't mean everyone has to do it, but at least understand that concept. And keep a clear count of number and an assessment of the anatomical size of the branches supplying each area. And then you will be able to assess that, yes, something is missing. Now, a few publications from Old Green Lane, which are very important teaching publications. You're always confused about anomalous coarse vessels. So one of the best papers I can tell you, you can note it down. If 1985, anomalous origin of left main from right coronary. How do you define the course? Now, this is how it is. Now you see this picture, how beautifully Dr. Brandt has drawn this. You see this circle here in RAO view, the artery has been drawn. And this circle, what does it tell you? When I see in RAO view, I see inside the artery. So it is end face, the mouth. That is why I don't profile it in the left main ostium in RAO view or RAO caudal view, right? And so these are normal ones. So if it is arising from the opposite sinus, that is the left is arising from the right, it has to finally go to the left because it has to supply on the left. So there are basically 4 ways that it can go. One is behind the aorta, one is in between the 2 arteries, then front of the RV outflow, as we all know, and last is from the right, dips down, goes towards the septum, gives a septal branch, and then finally enters the anterior interarterial. So this all you will understand if you have the concept of the heart behind the coronaries. And then I think I will not talk too much on this, but there are standard, this is very standard and you can understand that, take a picture of this or read the publication. The RVOD free ball course will always produce and always see in 2 views. Then only you will know that this course is caudal or cranial, anterior or posterior. You only have to know that much. So anterior cranial course is RV outflow. Anterior caudal course is septal. Posterior cranial course is interarterial, and a retroaortic course, which is behind the aorta, is always caudal and posterior. Invariably, when I ask people, the young guys, what is the course? In between the 2 arteries, because they always feel that from one side, that is the only way. No, there are 4 ways. Remember that. I will skip this. This is the congenital heart and the coronaries. I think it will take some more time, so I'll just skip that. This is another technique. The double in this is my technique. double inversion technique for coronary angiography viewing in dextrocardia. I published this in 2005 in the CCI. So I tell you, this is a very useful technique. What happens is when you have dextrocardia, if it is a normal congenital heart disease, dextrocardia, no problem, you're not chasing the coronaries. But there could be people with dextrocardia who develop coronary disease, coronary artery disease. Now there you could also get occlusions, you could get a lot of other things. So in that, there you have to, the type of pictures that you get is like this. You see this is a left coronary injection, this is a left coronary injection in one of the standard views, aleocranial. Now this is how the aleocranial looks, and it should look. This is a RAO caudal. Now this is how I expect. This is the LAD and the RCA here and some septal collaterals. This is the LAD in front, circumflex behind. That's how I want to look and interpret, but here I can't even make out which vessel is which. So how to make it normal, and that is the double inversion technique. There are two parts to it. One is you make a horizontal sweep reverse. There's a button in every cath lab of a horizontal sweep reverse. So you do that, then do a degree to degree reversal in the RAO and LAO angulations, keeping the craniocaudal same. If you want to see LAO cranial type of a picture, if it is LAO 50, cranial 20, make it RAO 50 and cranial same 20, you will see exactly the aleocranial picture. So that is how these pictures have been taken, and this is from the publication. Now this you see is the lateral view. That's how I expect. This is again a LAO type of view with a double inversion, and that's what I expect. This is the RCA. Okay. Well, types of lesions. I don't think this is all book knowledge. You all know that, but I don't go by that. Lesion assessment prerequisites, I think, as I told you, always avoid contrast layer frames. No. The other thing is there should be no overlapping or crossing vessels. When there are overlapping or crossing vessels, you get something called a MAC effect. MAC effect is one of those vessels could be filling faintly, especially if it's a smaller branch, or it is layered and less contrast is going there. So the less filling vessel will get even fainter at that junction, and you will see it even more severe. So this MAC effect one has to understand. And inching, I told you. So these are the ways to sort of analyze the vessel stenosis. Eccentric stenosis, this is a standard thing. We know that angiogram, they say, doesn't detect eccentric stenosis. Well, agreed, that's correct. But even in this, if you apply the knowledge, the concept of video densitometry, it will be, you will look like in this view, it will look broad. It will, in this view, it will look broad, that there is such a big lumen area, but the density will be less. It will be very faint. So you can partly make out that this is probably eccentric lesion. Eyeballing or QCA, I think if you do a proper eyeballing by the concepts that I have told you, you will be much closer to reality than even by QCA. QCA also depends on where you stop the frame, what is the MAC effect, how much overlap is there with other vessels, how much tortuosity is there, and things like that. These are stenosis. I think you all know that the relation between area and diameter. This is the other thing that, on exercise beyond 50%, some flow starts coming down. So you can have angina of effort in 60-70% lesions. But if there is a patient with rest angina and the lesion that you are trying to target, saying as culprit is only 60%, I don't think it will produce rest angina. Rest angina always means a lesion which is more than 80-85% or 90%. So this also one should remember. Several times you have patients drop with angina and the lesion done is 60%. That may not be correct. Now, lastly, I'll just show you a few examples. I can stop in between if the time is enough. This is what I was talking about, importance of aleocranial view. Now, this is the RAO type of view and an epicaudal view, close to, not truly spider, close to spider, which many people say is for left main ostium. I am sure you can't see any left main ostial disease, okay? And the next one from the same patient, LAO-cranial. And this is what I was talking, that the left main ostium is in progress. See how beautifully you have the Silhouette sign, you have the aortic wall here as the sinus wall and the left main coming out with such a long left main there. And you see how severe it is. You can see this in motion, see this in. So that is why LAO-cranial is the best view for left main ostium. And you want to know before giving 6 injections that the patient has left main ostial disease. So that's why I say this is the view to be done. Now, this is moderate disease in OM or wherever, hardly any lesion I can see. Another RAO type of view, hardly any lesion I can see in the OM. Maybe something I can see here in this, I can see, sorry, here, mild. And the same in a LAO view. Well, this is in motion, but I have frozen it for you at this point. See how severe it is. So we were missing it there because, as I told you, it is the circumflex is beautifully profiled in a LAO view. So that is why this is better. Now, what is the significance of this LAD disease? You see, well, sometimes I say FFR not only reduces the stents, it also increases the stents. Now, what is this disease? Well, the operator who did it, well, I was the operator, but the people who were interpreting in my class, some of them said, well, this is moderate lesion, nothing needs to be done. I said, okay, fine, good. This is the still frame of it to show you inch by inch. But you see, this is a moderate lesion, which is very long. And a long moderate lesion is important. And you see the FFR was significant. I can't read this, stop sharing has come there. It is 0.74 or something like that. So this is significant. And these are the lesions which we will miss, and the patient will continue to have angina because we will not do angioplasty on this. So several times for me, this also gets you more lesions to do. Okay. Now RCA CTO 1 or 2, see the to and fro flow. Now you see this. This is the collateral filling from the left side. RCA is blocked. So this is the total occlusion at the top with some bridging collaterals. And then distally, well, it was interpreted by whoever was interpreting it as 2 occlusions. I said, no, there are no 2 occlusions. There's only 1 occlusion. Why? Because I see to and fro flow here, which tells me that the flow which is seen here is going back, and the 2 are connecting. There is what do you call that? In the zone where the river is almost stagnant. So that is what it is. And then we just did 1 dilatation. Because of the disease, it was not flowing up, but there was no occlusion. Only 1 dilatation, and you got the disease, whatever, that's okay. As I told you, you have to fill the entire coronary before you start interpreting. Now you see this. This is the first angiogram done from the diagnostic catheter by the resident. And well, everything blocked. I can't see the LAD. I can barely see the circumflex. There's only 1 diagonal that also seems disease, and it looks horrific. Case nothing can be done. And then the same time a shot given with a good injection. Oops. You see that, and long enough, and during the later phase. Sorry, this is again the cursory diagnostic shot. Next one is with the guiding given by me. And then you see longer shot, and you have flow going down the LAD. It's semi-occlusive, and you have flow going down the circumflex, and you can do beautifully angioplasty of this case, no problem. Okay, so how much you give, how long you give is also equally important. The whole thing change, and then you get the results. Okay, so I think those examples should be good enough. This is our RCA. This is from a live case that I was doing in one of the I don't know, someone in the live sessions, and the operator who was there with me, he said, we have the RCA occluded here, and we have on the contralateral injection, very faint filling only in the distal part. So this is again diagnostic angiogram, and well, he said very long occlusion, very difficult case. I don't think we should do it. But then I had seen the angiogram from close distance. Some of these things can be seen only from close distance. I said, where is the catch? But I don't think you will be able to appreciate that in this picture. because I could see something filling here with to and fro flow, and that is what I showed with a better injection. Now you see the same with the guiding injection. So now this RV branch, the in-between part is filling through the RV branch and the distal part through the left coronary, and the occlusion is only this much, so we can do it, and we did it. Okay, so that is that. I think this we will skip. And with that, I think I talked about frame by frame analysis and inch by inch on how we do this. Okay, I think I'll skip some of these things and I will conclude. Okay. So to conclude, friends, what I want to say is that seeing or imagining the heart behind the coronaries forms the basis of understanding coronary anatomy. Understanding the coronary anatomy forms the basis of performing a good angiogram. And performing a good angiogram forms the basis of correct interpretation. And visualizing each angiographic run as a collection of images and not as one snapshot picture forms the foundation for interpreting flow patterns and stenosis severity. Orthogonal view forms the fundamental for knowing or understanding reality. Always, someone shows you only one view, I think that is not right. You should always show two views so that one understands both sides of the story. And it is skills of good angiographic performance and correct interpretation that finally forms the basis of a good and successful coronary intervention. So don't take this session of mine as only for residents or for consultants for angiography. I think at least I can vouch for it. It's the basis of my coronary intervention, whatever I do. Because you see what you know. I think this is what it says. And the best interventionist needs the cardiologist's mind, is to see the angiogram with a cardiologist's mind and the radiologist's eye. That's what I think. Thank you. If I think I've just finished.
Thank you so much, sir. Session.
I
And now,
you, that's the only issue.
no, not at all. Sir. It was such a pleasure, and now it is open for discussion with all the panelists. I believe that must be a lot of questions, and over to all the panelists to ask any questions, clarifications, and comments regarding the same.
Yeah.
So, Dr. Nitish, Dr. Harshvardhan, Dr. Vinod, Dr. Girish, Dr. Ankit, if there are any questions, please feel free to ask.
Thank you, sir. That was a wonderful disposition on how to perform an angiogram and how to interpret it. And I think so. It was very nice to see how that diagram that you have made it so popular across the country on how to report an angiogram. So I think so. That's one of the most important take-home messages for everybody, because there's no standard way of that is followed, and it's very important that all of us really understand how an angiogram needs to be reported. So thank you, sir, very much for explaining the details about that. So, sir, just as a question to you is like, often enough we have seen, like you very importantly described, that people do not perform a good angiogram because, they do not inject enough contrast. It's a very cursorily performed angiogram. But another problem that I note frequently is that you sometimes, especially when you're performing angiogram in women, the vessels look a little too small. So what would be your take on the utility if you were to see diffusely small vessels when an diagnostic angiogram is done? What would be your take on giving nitroglycerin intracoronary to open up the vessels, and would you use it routinely in practice? That you did?
Well, I understand what you're saying, and several times the vessels look narrow because of, well, spasm could be there, so you can relieve the spasm part by nitroglycerin. But the other thing that is there is for you to assess whether this is narrow because of spasm or there is true disease all through, because as we all know, atherosclerosis is a generalized disease. So what happens is, certainly there will be some part of that angiogram where the artery would be probably normal. Even a small part, say left vein is normal, or whichever part is normal. Considering that as normal, then you have to throw a question as to what should the normal be here. Like if I see, and then assess this as a stenosis. Like it is maybe moderate disease all through. So if you have some segment which is normal, so if the left main cell is 4 mm in your impression, and the entire LAD looks 2 mm, it cannot be 2 mm. If the left main is 4, the LAD has to be at least 3, 3.5, whatever it is in the proximal part. So you have to throw that. That's how I do. You have to throw the question as to what should the normal be, and then assess this after having taken care of the spasm part. I think that is what should be done. And one more point which I would like to add: you should, in interpreting stenosis, sometimes you should interpret it more as how much is the jar full rather than how much is the jar empty. This will take away your oculostenotic reflex, because I told you several times, if you analyze rationally, then neither you will have the oculostenotic reflex, nor will you overdiagnose stenosis. Smaller stenosis in big normal vessel is always overdiagnosed. A 50% lesion also will look like 90 to you, and a moderate lesion, as I showed you in the example, which may be about 70%, may look only 20%. If there's a
Sorry, I was muted. No, I was saying that just a comment. I think it's very important for all the people who have logged in to understand the importance of what Dr. Goel said about panning the field when you do an angiogram, because you're never going to see blocked vessels or vessels that are not filling up unless you pan the angiogram. And I think so. It's very often forgotten, especially when there are people who have just started to doing an angiogram, of not panning enough and looking at the entire heart and injecting long enough and waiting long enough to see the levo phase before deciding an angiogram. So thank you very much for on that. What would be your
yeah,
take
that's
on
a
the
very important.
abnormal vessel? So like
Sorry,
you
I
said,
didn't
in
get
the
it.
abnormal, for example, not so infrequently you see circumflex that arises from the proximal RCA, and people
Yes,
sometimes miss those vessels. They have a diagonal and they miss that. They
yes,
mistake the diagonal for the circumflex and
circumflex, correct.
forget to look for a proximal circumflex. So how would you
Yes.
advise a novice how not to mess up a circumflex?
Yes. So now this is an important question. Now, how not to miss? My diagram tells me, my diagram means because you have to work on the concept of areas of the heart, have they been covered or not. Now, if a circumflex is arising from the RCA and you have not filled it, your diagonals or the branches coming from the left system, from the left coronary, cannot be as big to cover for the entire circumflex territory. You will see that the RCA is average size or small or whatever it is, and the diagonals are also small, hanging at the top. So where is the circumflex supply coming from? If you think in that term, you will immediately get an answer that maybe the and it is not blocked also because it's not filling through collaterals. Maybe it is arising from somewhere else. So by that logic, and when I draw the diagram, then what happens is, as I showed you when I was how to draw, I will only be able to draw two tiny diagonals at the top and one PDA from the RCA, and I will have nothing else to draw. Immediately it will tell me, oh, you missed the circumflex. And then you know that circumflex most commonly arises from the RCA or the right sinus and comes behind the aorta. That we all know. And then we will be able to go there. You get it? So it's a question of thinking, is how you think while you're doing the angiogram. That is what will lead you to the correct situation. I hope I can make you understand.
So what is your experience with the presence of the intercoronary collaterals rather than the other introp collaterals? How commonly do you see them in your practice while you are doing
Sorry,
interventions?
intercoronary collaterals versus
Yeah, the
ipsilateral.
routine collaterals. Yeah.
No,
The
the
routine, yeah.
intercoronary means between the right and the left, and ipsilateral means within the same system. So you don't need to inject the other side. So both ways it is there. Well, we did a paper on CTO. There is a score that I made, which is published in the Asia Intervention. In that, what we found was if the collaterals are poor, then the success of CTOs is less because we need good. So sometimes actually a good total occlusion with big distal vessels, good filling of that distal vessel with big collaterals is more successful when I do CTO intervention than faint little collaterals and the distal artery filling faintly. So it is like that. And I think about 30% would have ipsilateral collaterals and 70% would have it from the opposite side. That is what
So
my conclusion.
my question was relevant to the open-ended circulation I was talking. The typical open-ended circulation, which has all the three muscular layers from RCA to LED to left system, and also from LCX to the right system. Often we see, and they have been differently addressed, and they have been found to be of great utility, especially when people are addressing the chronic total occlusion. So, and they have not been classified by the Rentrops
I'm
classification.
sorry. I think I'm not getting your question right.
Sir, what
I'm not getting it.
I think what Mohit is talking about is intercoronary communication rather than collateral.
Okay,
You know,
okay.
yeah,
Intercoronary, that is like,
yeah,
those
Yes,
communications, maybe they are congenital communications, you mean? It's
yes,
like fistula.
yes,
yes,
sir,
sir.
yes,
Yes, sir.
Well, they are very uncommon. I don't think so.
yes.
They are very uncommon.
They're very
They are very,
uncommon.
yeah, I would say they're very uncommon.
Sir, a
That's what I
question.
feel.
You have not covered about RC arising from left sinus, sir. So, what
Well,
would be your
it will
approach
be
in
the
such
same.
situations?
It will be the same. Ours, I told you and showed you the
Course.
LCA arising from right sinus. RCA arising from left sinus will behave in a similar fashion. It will have again the same four roots. When it is coming from the left, say it's a branch of the left coronary, from the it will either come in front of the RV or flow tract or in between the two arteries or behind the aorta or maybe take a septal course and just exit into the right AV
RV.
group below the right sinus and that fibrous trigone area, right? So it will follow the same thing and it will have the similar loops as the left, and you will have to differentiate the roots on the same.
So once a patient, fellows often ask that a patient has a severe LV dysfunction with an ejection fraction of probably you say 20-25%, and you see that there is definitely a viability. So while you are doing and performing an angiogram in such patients, do you still recommend taking all the views in the similar pattern, and would you still recommend taking an LV in an already established case, or would you recommend the abridgment or decreasing the number of angiograms in the interest of the patient?
Yes, you see, if the I can reduce some of the coronary shots, I can certainly reduce some of the coronary shots because the way I was taught and how I do the coronary angiogram is the first shot that I have done, I do the shot, I also interpret everything is over there, and then I know that series of five shots have to come to complete the entire picture, every segment of each artery. But yes, if I have constrained on the contrast, then I can limit the shots. And well, if I have a constraint on contrast, especially if it is renal failure, which is on the borderline, then I may not do a LV angio. But by and large, if a patient has a MI and just the reason for not doing is that his ejection fraction is 25%. I will still do it, believe me. How I will do it, I will give a shot of Lasix 20 milligram before. Well, EDPs could be high. I don't want to be, well, I have done it and I have no problem. The EDP, you give a shot of Lasix and you can do it, and how you give a little lesser volume, because finally you see what happens when you do a coronary angiogram. You give over 80 ml of contrast. I'm talking in average. You give over 80-90 ml of contrast. Now LV angio can be done in a routinely, it will be done in 20-22 ml of contrast, right? So if I have given 90 ml, I will be 110 ml. What difference? If the patient will accept 90 ml, he will also accept 110 ml. And if somehow I can reduce 90 to 70 and then add, instead of 22, I add a 16 ml angio, you can also do minimum. If I do, you have to still do 16 ml, because if you do less than that, it will not fill at all and it is a waste. That's 15 ml is also gone. So you have to rationalize yourself, and especially with MI, because I want to know how the LV is exactly before I will decide on his intervention. So I will
Finally, sir,
try my level best to do it, depending on this. But I'll try my
and
level best to do it.
sometimes you also look for the coronaries which are not originating normally from the normal sinuses, and you often find that they are quite often, rarely though, we find them that they are arising from the ascending aorta and some other place.
Yes,
So, which are
yes.
the catheters that you recommend to the novice? Routine catheters, because not all the people would be having all the catheters, and most of the
Well, yeah, you should
angiography
have some
they
kind
have
of.
the non-selective shots. So, what are the catheters that you recommend to approach such cases?
Actually, very high arising RCAs. I just had one case about 2-3 weeks back. It was arising at least about 3 centimeter above the usual right. I think the best catheter to hook these is, whenever I don't find right, I take a Amplar's AL catheter, AL1, and that AL1, you just put it down and don't rotate in any direction. Most of these arteries, when they are rising high, they also arise slightly anterior. So, because what is happening when you rotate it, you are trying to get the catheter anterior and then it moves to the right. Right sinus is right and anterior, we know that. So normally when a regular catheter JR or Amplar's, whenever it goes into the ascending aorta and is pointing backwards is posterior and left. So you do a clockwise rotation, so you try to bring it anterior and right. So here you will not rotate it, you will just put the catheter straight down, and most of the times Amplar's is able to hook it, and that was a case, and I think beautifully it was hooked. 2 times his angio was done, and it was never hooked. It was never hooked. So I find Amplar's as the best one for this. The other catheters, like the maybe if it is more on the right, like a bypass in that position, then maybe a right coronary bypass catheter, which is a straighter version of JR catheter, that could do it. But I don't have actually bypass catheters in my lab. I only
And
have, and most of the things are done with AL.
another thing, sir, that often you see, very, this is quite common, that you see the right coronary artery which is originating from the left sinus, near to
Hmm.
the left sinus. So, which is the general catheter, a normal
Ah,
jail wouldn't,
okay.
and
Okay.
you really use a different way to engage this. So, what is
You
your
see,
approach in these
right
cases?
coronary arising from the left sinus. You see, मैं दो language में बात कर रहा हूँ. In the sense that means it is
Sure.
also slightly posterior. It's also slightly posterior,
Yeah.
because I always keep the heart behind. मतलब, you understand me? I always keep the heart behind. As I told you, my first slide was imagine the heart behind it. So, because I can see RCA is not coming from the right sinus, and so I imagine the right sinus as the right and anterior place and slightly high, and then the left sinus left and posterior and slightly lower. And then so this artery which is arising from in between the two is usually arising posterior also. So sometimes lesser rotation will hook it instead of the full rotation. Lesser rotation will hook it, or else out of plane left catheter. When we used to do the Judkins technique, a out of plane left means you have the Judkins catheter and you make it out of plane. So you twisted the tip in a way that it is not in plane. The tip is out of plane. So that could also hook artery which is arising very close to the left coronary, the right coronary artery. I hope I could.
These are that's fine.
You're right.
Any other questions we have, or we close the session? Dr. Ankit, Dr. Girish, Dr. Nitish.
Just one question from my side.
Yeah.
Sir, do you routinely give vasodilators prior to coronary angiogram?
No. As I told you, I keep the patient's confidence, the stress level, and the pain, the minimum. There'll be no spasm. All these things happen because of the stress, the pain, and anxiety. So if you can keep control of these three things on the patient's part, usually it should not happen, and I don't give any.
Okay, thank you so much, sir, for such a wonderful session. It's as always a pleasure hearing you so many secrets. Especially, I really loved the views of RA on LO30 that you told to engage the grafts. That was really interesting. That beautiful, and these small tips that make sometimes.
Everyone could have this small tip. If you take even a small tip, I'll be more than happy.
Yeah, Dada Dadi ke secrets जिसको हम बोलते हैं, and it's always a pleasure, sir. And we look forward to have more sessions. And this is the first of the webinar in that. And my dear friends, those who have taken out time, we had more than 200, 300 people joining us today. And if you, in case you have missed this particular session, this will be available on the Delhi CSI official YouTube channel of PG Track Delhi CSI. And you can listen to these sessions. If you have not been able to capture the pictures that Dr. Goel was telling you, don't worry, you can easily download the whole session. You can listen. You can actually again read those articles.
So you captured my entire talk.
We will do that, sir, definitely. No, we won't make it. So thank you.
So मेरी consent ले हो भाई. Chalo, that's something like.
We won't do it without any consent.
Mohit, one last comment. Sir, many a times when some things are not going in or passing in easily, we ask for a deep inspiration. So what exactly it does? What exactly it changes? What is the science behind it?
Yes. No, very good point. You see, actually, it changes the entire anatomy. When you take a deep inspiration, the heart's position changes, and the moment the position changes, then everything changes, and that's why the catheter hooks up. You see, you are just changing the position. That's all, nothing else. There is nothing like inspiration will get it in. No, your heart's position changes. As you can understand, when you take a deep inspiration, the lungs expand, so heart becomes longer. Right? So when it becomes longer, then the entire anatomy changes. Everything is on that anatomy of the heart. Okay.
Yes. Thank you so much, sir. Thank you for joining us, and we'll trouble you in near future also for taking special sessions with our residents and all the young cardiologists, and especially it's a great learning for all of us. Thank you so much. Thank you, Dr. Nitish,
Thank you.
Dr. Harshvardhan, Dr. Vinod Sharma ji, and Dr. Ankit, Dr. Girish. Thank you so much.
Thank you, sir. Thank you.
Okay. Thank you.